Perfect. Thank you. I did want to just highlight that the Maternal Mortality Review Committee report has been released in the last couple weeks since we last had an echo. And this is available online through the Iowa HHS website. If you just Google search Iowa Maternal Mortality Review Committee report, you will find it. But I do want to encourage people to obtain a copy of this, read it, share it in your facility and your, within your healthcare circles and communities otherwise, because really that's what we were hoping with the report is it would be a way to disseminate information to Iowa's healthcare community about opportunities that we have to reduce maternal death in our state. All right, so we are here today talking about obstetric hemorrhage, and next month's focus is going to be on hypertensive disorders. So do please think about submitting a case. Then in June and July, we're going to pivot and focus more on mental health in pregnancy, and we'll have some experts in perinatal mental health along with us leading that. So I think that's another great opportunity to talk about complicated patients with mental health conditions, or even just questions about managing depression, anxiety in the perinatal period. So I really hope people will consider submitting cases, even if they don't feel like they might be as complicated, just, even just sort of what to do with more routine and common conditions would be great too. Okay, so I'm going to talk today about obstetric hemorrhage. Just my disclosure is that I could talk for like 5 hours about obstetric hemorrhage. I do think it's important for people to recognize that this remains a leading cause of preventable death, both in our state and nationally. In the new report, we identified that hemorrhage was the second leading cause of pregnancy-related death in Iowa. The leading cause was infection, and probably given the time period, no surprise to anyone on here, the majority of those infection-related deaths were from COVID-19. So if we had excluded COVID-19 related deaths from this, we actually would have found that hemorrhage is the leading cause of maternal death in our state. So I think it's important for people to recognize that this happens. Many are aware that hemorrhage is a leading cause of maternal mortality globally, but often not recognized how much it still contributes to maternal mortality in our country. Nationally, in 2021, hemorrhage was responsible for just under 10% of maternal deaths in our country. And where this becomes really important is that death from obstetric hemorrhage, particularly when it occurs inside a hospital, is almost universally considered to be preventable. And so when we think about our opportunities to reduce the burden of mortality in pregnancy, this is actually a really important lever, because we should be able to prevent this from happening in the vast majority of cases if people are in the hospital when they're hemorrhaging. And so some of the other leading causes of maternal mortality become more complex to prevent, particularly things like cardiovascular related conditions if somebody is coming into pregnancy already in a poor state of cardiovascular health, for example. So this is a really important topic and an area where we've done improvement work in Iowa, but we probably still have a little bit more work to do. So again, thinking about the portion of deaths related to hemorrhage, globally, hemorrhage and infection are the leading causes of maternal death, and approximately 1/3 of maternal deaths in the world are from hemorrhage, versus in the US, approximately 10%, or as I put on the last slide, 9% of deaths are from hemorrhage. However, when deaths in the US are reviewed, 90% or more of them are thought to be preventable. And so this is, again, a place where we really have an important role to make sure that we're recognizing and responding appropriately to obstetric hemorrhage. So key best practices, I'm just going to walk through kind of key best practices related to obstetric hemorrhage for folks on here who work on a labor and delivery unit and may have been involved in our QI work on this a couple of years ago, whether or not you're a team leader, maybe even we're actively aware we were working on this. Hopefully this is all going to feel really, really familiar. I'm not going to present any groundbreaking information here. This is just fundamentals of taking good care of your patients. So the first thing that we want to think about is recognizing that people have different levels of risk of experiencing a hemorrhage at the time of birth. And prenatally, particularly for centers that are a level 1 or maybe even some level 2 hospitals, you really want to make sure that prenatally you're identifying patients that might be at exceptionally high risk of hemorrhage or otherwise be a complicated patient to administer a blood transfusion to. For example, somebody who has multiple antibodies in their blood and only a small portion of the blood available in a blood bank would be compatible. We want to make sure that people are delivering at a center that has the appropriate resources to take care of them. So placenta accreta patients should be delivered at a tertiary care center. In Iowa, the university is the accreta center, and we typically deliver all of the known or suspected accretas in the state and have a specialized team that focuses on care of those patients. Again, another situation are patients that have multiple antibodies. You want to make sure that your blood bank would have blood available for that person on short notice. And if they would not, then you want to think about if they should be sent to a higher level of care facility within your region that is more likely to have appropriate blood for them. We also want to recognize that prenatal anemia is an extremely common condition to arise in pregnancy. And if we can optimize prenatal anemia, then essentially everybody is coming into their birth with a more full tank and can probably more safely tolerate some degree of blood loss before they start to get into an unsafe situation. And so making sure that we're following standards on management of prenatal anemia, treating with iron therapy, and then recognizing people who maybe need to receive IV iron if they're not responding or not tolerating oral iron. And then we want to be doing risk assessment when patients are coming into the hospital to give birth. So everybody should have a hemorrhage risk assessment performed upon admission. And then if they're a laboring patient, this should be reassessed during labor, ideally right before they deliver, to recognize any new risk factors that have arisen during the course of labor. Have they been in labor for a long time? Have they been on high-dose oxytocin? Do they now have an infection that's going to make them at increased risk for uterine atony? We then want to align that preparation, that known risk. We want to align that known risk to our preparation. So it's only going to help us so much to know that someone is at increased risk. What we really want to do is be more prepared. And so at a minimum, that should include making sure that you have essential supplies to manage a hemorrhage available already in the room. Most facilities are now bringing uterine atony medications into the room when somebody who is at moderate or high risk for hemorrhage are delivering. I've also observed that in many facilities, particularly those with a little bit less volume, will just bring their entire hemorrhage cart into the room. And I think that's a great strategy. If you're a really big facility where you routinely have multiple patients delivering around the same time, it may not be feasible to bring your cart into the room because then somebody else might need it. But thinking about, are your rooms stocked with the supplies that you would need? And again, are you getting those medicines there? Post-delivery, if someone didn't hemorrhage at birth, we still want to assess their risk for a delayed postpartum hemorrhage. And so we know some people are at risk of bleeding excessively in the first 24 hours after they give birth. Again, a lot of the same factors that might have been present during labor, but then also things like maybe having had an operative vaginal delivery or a very large infant. And so thinking about being prepared to manage that patient, I think at a minimum, thinking about maintaining IV access in somebody that you think is at risk of continuing to bleed or having a significant bleed later, we want to make sure that we haven't removed our IV access. And so that would be a recommended intervention, is just to keep that in for 24 hours so that then you can quickly respond if somebody does start to bleed again. You guys are all aware there are many risk assessment tools. I don't think any one of them is perfect, but pick one or customize one to your facility and use it consistently. The next key best practice is how we measure the blood loss. And so we think about an obstetric hemorrhage as being any time somebody loses more than a liter of blood associated with childbirth. And that could be including blood that happens that is lost during the course of labor with like an abruption where somebody may bleed before they've given birth, and then ongoing blood loss that may happen within 24 hours of birth. That doesn't necessarily mean that you have to weigh all of the blood that comes out for 24 hours after birth. Most facilities do not do that, but recognizing that this is a general definition and it applies to people who have both a vaginal birth or a C-section. Quantifying blood loss simply means that we're measuring it, not estimating it. And so that includes weighing things and subtracting the dry weight and then measuring liquid blood in some sort of volumetric container. So an underbuttock drape that has graduated markings on it, a suction canister in the operating room that has graduated markings on it, or tells you how much fluid is in it. This is not perfect. But we know that it is superior in every single study of QBL. It is superior to estimating. And what's scary about estimation is that in almost every study, it shows that at higher volumes of blood loss, we tend to underestimate the volume, and we actually overestimate it at lower volumes, which is less of a concern from a safety standpoint. I hear often that people feel concerned that it's not perfectly accurate, but I just want to reference that it is not perfectly accurate, but it is better and more accurate than estimating. And people don't get better at estimating over time. There's studies that had, seasoned faculty members estimate as compared to like first and second year residents, and the residents were actually better at it than people who had been practicing obstetrics for a long time. So that may not feel intuitive, but in fact, we don't get better at this with time and experience. So it is one piece of information that should be taken into consideration along with the patient's vital signs in your assessment of the hemodynamic status of a patient who's just given birth. And then cumulative blood loss is kind of building on this quantified process to recognize that the blood loss may not happen all at once. And so we really want to be thinking about cumulatively how much blood is this person lost. So let's say somebody had an abruption, and we were able to measure some of the blood that they had lost before they maybe went to have a C-section. And then we know how much blood they lost in their C-section. And then we continue to monitor how much they're bleeding in the first couple hours afterwards. We really want to think about all those numbers added together because that's how much blood this person has lost very, very recently. And that can be helpful. Or if we have a vaginal birth and we have some blood loss in the room, and then we actually take the patient to the OR because we need to do a complicated repair and they lose some more blood in the OR. We need to add those numbers together, not think of them as two separate blood loss events, because that's essentially how much blood the person has lost. So quantification is super important because when we look at deaths from maternal hemorrhage, the two themes that consistently emerge both here in Iowa and nationally is that the clinical team failed to recognize how much blood somebody had lost and essentially failed to recognize that the person was approaching shock. And then there's a failure to respond very quickly because, again, you don't recognize where you are in the pathway of hemorrhagic shock. And so then you're not responding appropriate for the level of the shock that the patient is in. Where we get into trouble is that our obstetric patients don't show us the manifestations of hemorrhagic shock the same way that most of the other patients we take care of in the hospital do. So, for example, our anesthesia providers are very accustomed to taking care of middle-aged and older adults in the operating room. And those patients are very likely to start showing abnormal vital signs very early in a large volume blood loss situation. And so that can lead to a sense of comfort that the person's vital signs are always going to show me that I'm approaching shock and that I need to respond. Unfortunately, obstetric patients will not likely show significant changes in their vital signs until they've lost about 30% of their blood or more. And the first sign that they're going to show is tachycardia, but they may already be tachycardic, or it may be very easy to explain the tachycardia from another reason related to them being laboring or maybe having an infection. And so then it can become very tricky. And if you wait until the hypotension emerges, you are already very behind. And so we actually have stages for obstetrical hemorrhagic shock. that roughly equate to the volume of blood loss. But again, everybody's going to respond a little bit differently. People have different sized bodies. They have different amounts of total blood circulation. They have different pre-delivery hemoglobins. So this is just kind of a rough guideline, but it's worth pointing out that for many patients, you're not going to see them begin to show you some hypotension until they've lost about 2 liters of blood. And then at this point, if you're not starting a transfusion here, you're really behind. And so if it takes you 30 minutes to get blood from your blood bank and you don't call for it until you see hypotension, then at the rate that somebody may be bleeding, by the time you have the available blood, you may not be able to transfuse it very quickly. So this is why, and I'll get into stage-based hemorrhage management, as hemorrhages are escalating, we need to have a sense of how far into the blood loss we are, and we need to be preparing and thinking about availability of blood so that we can transfuse it as soon as we believe we need it. And this is unfortunately what we've seen in some of the death cases, is that the transfusions were started late and not until somebody was in a very profound stage of shock. Team communication is really important. One thing that I've observed in visiting facilities through the perinatal program is that there's not always really clear communication between the nurses who may be measuring the blood loss and the provider who is performing the cesarean or the vaginal birth. And so this is a common recommendation that I have, is that for people to really get on the same page, if the nurse is measuring the blood loss, especially if they're doing it in real time, there's no reason that the provider should be recording a different blood volume as what they estimate the person lost, unless there's concerns that the QBL was unable to be accurate in that case due to, a lot of mixing of amniotic fluid, for example. And so I encourage all facilities to really make sure you have a streamlined process for this. Practicing it with every birth will allow you to do this more quickly, so that when you have that big hemorrhage that will come when you least expect it, you are really, really used to doing this very quickly, and you're able to do it in essentially real time. So the final key practice that I have around hemorrhage management is stage-based hemorrhage management guidelines. And these essentially outline in kind of 2 areas how we want to be thinking about taking care of somebody who's bleeding. And so the obvious part that I think everybody always thinks about, and people who practice obstetrics are trained to do, is thinking about recognizing the source of bleeding, which 80% of the time is going to be uterine atony, but 20% of the time it's not. Going through a systematic approach of escalating interventions to get the bleeding to stop. And so that includes using uterotonics in an evidence-based fashion, using ones that work quickly first, avoiding use and routes of medicines that are not effective, such as placing Cytotec rectally, which is hopefully about to finally come off of ACOG's documents because it's been essentially eliminated from most other groups' recommendations. And then also making sure that we're assessing for other sources of bleeding if the uterotonics are not working, or we don't believe that uterine atony is the source of the bleeding after doing an exam of the patient. This part we've talked about a lot when we worked on hemorrhage as a state. The other arm of a good hemorrhage management guideline for a facility is also aligning that hemodynamic resuscitation. So as we are having more blood loss, we want to have a standard approach of escalating our interventions. I would recommend, and most societies and groups that have published on this, such as the CMQCC and the AIM program, would suggest that once you reach a hemorrhage, a liter of blood loss, you should be placing a second large bore IV. You should be bolusing IV fluids. If you're not in the operating room with an anesthesia provider, you should be calling for one. If you are in a facility that does not have an anesthesia provider in-house, think about your friends in the emergency department who are very good at resuscitating patients. You should be calling for blood products. This doesn't say that you need to transfuse everybody who loses a liter of blood. You probably don't, but you want to get that blood up on your unit so that if they do continue to bleed and start to deteriorate hemodynamically, you're ready to hang the blood. And then you want to think about a level of empiric transfusion. And And each facility may have a slightly different approach to this there, and there also will be some individualization. I can tell you that at UIHC, we realized that virtually all of our patients who lose more than 2.5 liters of blood in a quantified system end up getting transfused. Even if we don't transfuse them empirically, they're so anemic the next day they get transfused. So we recommend now empiric transfusion at 2.5 liters of blood, even if the person appears to still be hemodynamically unstable, because we just feel that they don't end up avoiding that blood transfusion. We also want to make sure that we are not relying only on visualized blood to tell us how much somebody has lost. If someone is demonstrating vital signs abnormalities that could suggest that they are entering shock, we need to recognize that sometimes people will have concealed hemorrhages, they'll have a pelvic hematoma or a vulvar hematoma, and you can't see the blood, you can't measure it, but they are still losing blood. And so we need to have a high degree of suspicion. And in complicated cases, somebody might have some of both. And so you might be seeing a liter of blood loss right in front of you, but they might be putting another liter into their pelvic sidewall. And so, so if they're showing signs of hemodynamic instability, even if you don't see that much blood, you need to assume that it's a possibility that they're bleeding internally. It looks like there's also a question about oliguria and anuria. I think that that's going to be a late sign of somebody who is in a hypovolemic shock. It's certainly concerning if you see it, but I suspect that most of those patients would have shown you some vital signs abnormalities before then. So I think it's something that needs to be evaluated. It becomes complicated when it's also a patient with preeclampsia, and they might have that related to their preeclampsia process. But this is where we really have to be, have our thinking caps on, not attribute a concerning maternal early warning sign to something else, and make sure that we're never missing that somebody could be losing blood. So the last kind of just like summary that I have is, again, many of the names on here are very familiar to me. I know that you worked on this with us. So just to make sure that you are using the tools that we worked on, when I come to see you with the perinatal program, I ask you to show me your hemorrhage cart, and every single one of you have a beautiful hemorrhage cart that has all of your supplies. You've got scales to do QBL. Most facilities are doing it pretty consistently, but we just are missing a little team communication. And again, I think we may have some opportunities from reviewing events from the mortality review, as well as some of the case reviews at facilities, to make sure that we're really being aggressive in our resuscitation of somebody who's bleeding. And so a lot of that is team coordination and communication, thinking about how we're making sure everybody has situational awareness. Smaller volume facilities are naturally going to see these events less frequently, although I would really argue that if you work at a really large volume facility, you may still see it infrequently just because there's that many more staff members. So this is a really important topic to SIM, and really focusing on mobilization of resources. You know, how do you activate the MTP in your facility? If you're a small facility, how do you mobilize resources from elsewhere in your hospital to come and help you, because inherently it's going to be like 2 a.m. on a Sunday when this happens. And then review the cases that happen in your facility. It may help you understand where there are gaps in your system, where things are not happening quite as you thought that they would or that they should. And that can help you understand where you may have some opportunities for targeted improvement. Okay.